that good sample history.
Yeah.
It's always good to review it. It gets overlooked so many times, but it can save you so many times as well. So we've got the sample history, signs and symptoms, allergies, medications, past pertinent medical history, last oral intake, and events leading up to. So past history, extremely important to help with these. Like last oral intake, you got your dialysis patients. Important to know about,
And then the second one here, the change in bowel habits and urination is huge because, like in the case of when was the last time you peed? 3 days
ago. How much
ago.
you've been peeing, and how if you're going to a nursing home and they've got a Foley catheter in, because these Foleys, you look at them, they're urinary tract infection.
Oh And that's a little, in case you don't know, that's a little quick note. I learned this with my grandfather, and I had already been an EMT and a paramedic for a little while at that point, but we don't deal with the Foley catheters in the bags as much in the field. But if you walk in to pick up a patient and they have a bag and that bag is cloudy, that's an infection.
All right.
And typically, the more cloudy it is, the worse the infection is.
And you want to make sure you save some of that.
Yeah, bring the bag with you or whatever. Yeah,
the bag's usually, but it's so easy for us to, you got a full bag there, like, I want to drink, because I don't want to carry this full bag, because have you had one of those leak in the back of your truck? They come unclamped.
Yeah.
It makes a mess. It's not fun. So what do we do? When we get there, we look at the bag and we dump it, right? But you're going there, it's important, before you just dump a Foley bag, you need to get with the staff and say, hey, we need to empty this Foley so that it can be recorded. That output needs to be recorded, because that's important. Mm-hmm. And it also is in that chart so they can document, okay, he's only putting out 500 cc's a day. Well, what's his input been? Well, because they keep up with that too.
Right.
They should be.
Right. They should be.
Dietary keeps up with it. And if they know that he's getting 1.5 liters a day, then there's a potential problem there. So it's important. It may not seem important to us. We just go in there and empty that bag. But in helping diagnose this patient, it's an important thing to know.
That weight loss can indicate all kind of things, but a big one is pregnancy.
But it's not just, they put weight loss in here too. What about weight gain?
Yeah, not passing water. You're getting water weight put on you.
Yep.
Yeah, sudden weight gain.
To retain that water. And so, because whenever you take somebody to dialysis, what do? Before they go on the chair, they get weighed.
Before and after,
and they get weighed coming off. So if we're going out on somebody and we're seeing, hey, they've gained, all of a sudden in the last few days, they've gained this weight. And how do we know that? Well, we can look at things like, look at their socks. Is their feet expanding? Their belt,
and their socks leaving marks on their legs. Yeah.
Are they able to button their pants? Is that in order to put their shoes on and stuff like that? Concurrent chest pain because these patients, if they get fluid overload and stuff like that, it can cause problems.
Right.
And we want to look at any other signs and symptoms, especially pain. Like we said, abdominal pain, bleeding.
Yeah.
Have bleeding there as well.
Now, with the chest pain in dialysis patients, when I talk to active students, we talk about those non-emergency transports, and that dialysis is the number one transport you're going to do. And I thought, I was like, no, you got to watch for a code every single time.
Every time.
Because their electrolytes are off, because we never quite dial in just right? I mean, we're just human. And even as close as they get, we don't know literally how the body's processing it at that second. And then like you said, you've got all the backup, you've got all kind of stuff wearing on it. I mean, every time you're taking a dialysis patient, you need to be on the watch for a code. And then you see their eyes light up. I was like, well, I thought everybody told me it was just a granny toes. Like, no, not dialysis patients.
It can be.
Typically it's going to be, hey, we checked your vital signs, we talked to you, everything's good. But when it goes bad, it's not going to be, oh, I don't feel well. It's going to be full code very quickly.
Before you know, and I like to say complacency is one of our biggest enemies.
Yeah.
We go out on dialysis patients. We go out on them today. Nothing happens. We just get a set of vitals, drop them off. We go pick them up, and guess what? Same thing. On Monday, Wednesday, Friday. Guess what we do next week? Monday Wednesday, Friday.
Yep.
The next week, Monday, Wednesday, Friday. Next month, Monday, Wednesday, Friday. 6 months from now, Monday, Wednesday, Friday. But you know what? Like month number 9,
they
crash. So we don't know when it's going to happen, and but it eventually does happen, and you don't want to be that one that's complacent.
Is it just me, or is dialysis clinics never open on Tuesday, Thursday? That's what it seems
they do Tuesday, Thursday, Saturday.
Yeah, do they?
Yeah, it's Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday.
I know they were doing something, but that was the schedule. It was always a Monday, Wednesday, Friday schedule when I picked up and dropped off. You know, it was weird. So, of course, any other signs and symptoms.
But think about it. Whenever you are picking up that dialysis patient and you're taking them to the chair, they are going to be acidotic. Their pH is going to be on the acidic side. Whenever you're bringing them off the chair and taking them home, they're going to be more alkalotic.
They're going to be basic, is what you're saying.
Yeah.
I got you.
Get that good secondary assessment in, a physical exam. We want to make sure we're looking for those turds, right? TRD. Yeah, everybody laughs when I say it. But
it's great. I mean, you wrote tenderness, rigidity,
and distension. Those turds, right? Looking for it. And if you have that, it's an acute. Consider that an acute abdomen, which is potentially surgical at that point.
Right. And you need to look at it. You have to look at it. I've seen it very rarely, but I hate when somebody starts feeling over the shirt. I'm like, what are you doing? You got to get that shirt off, man. What are you doing?
And we're looking for that bruising around the umbilicus, right?
Yep.
Bruising in the flanks and stuff. And if we don't see it, we didn't do it, right? And if, at least hopefully we would be transporting at that point.
Yeah. Yeah, if you're doing this part of the assessment, you should be in the back of the truck on the road.
Yeah, and how many times is this just brushed over? We want to make sure that we get a good set of vitals on these patients.
I hate to admit, but on some of these transports, especially if the patient was sleeping or just out of it, I did visual vitals on some of them. I look back going, that was a dumb... Yeah, it was. It was a complacency. It was ego of, I know what I'm doing, I can see it, you know, and
then what happens, but you just think that patient's sleeping.
Yeah, and they did. Yeah.
You know, that has there has been, and I heard about this just here in the metro area this year, where a crew picked up a dialysis patient, took them to dialysis, put them on the chair, got the tech or the nurse to sign and they left. And whenever they walked over there, they just
the patient
assumed the patient was sleeping. No, patient was dead.
Man.
That was a stink.
No kidding. I mean, and that's it's not on the dialysis clinic. It's on the nursing home first maybe the nursing home, then definitely the medics, because
or the home or people at home
or wherever now if it's people at home, they might not have somebody who knows how to check them out. So it's definitely, I mean, when it falls down on the ambulance at that point, because
they transport.
How hard is it? And that's why I'd put a pulse ox on. Okay, there's a visual pulse, and the number and the O2 set, and then I just pencil with the rest. And that, how hard would it have been just to put on a blood pressure cuff and do a blood pressure manually or on the monitor?
Yep, and we get away with those little things, but over time, you don't want to be that one, because then everything comes into play. You get investigated, and you get in trouble, and you don't want that happening. Then we need to reassess these patients. If we're doing a dialysis transport, there should be time to reassess.
There should be at least 2 sets, if not 3 sets of vitals on a dialysis patient.
And if it's an emergent, then, every 5 minutes for that emergent patient, at least.
Right, for all the other...
For the other patients and stuff. Look at those interventions. Look at treating for shock. What are we doing for that? And providing that emotional support for the patient, which is important. We get away from that so many times. We need to let them know that we're here.
Yeah.
And if it's like that patient that couldn't pee for 3 days, letting them know, hey, I'm sorry I can't do anything, but man, we're going to get you to the hospital as soon as we can.
And I definitely have seen the difference in, not that particular patient, but let's just say it was him. If he's in the back of my truck, it's like, man, I know, buddy. I know it hurts. There's nothing I can do. We're getting there. And it keeps him calmer. And then you go into the ER, and they don't provide the care. Not because the ER is evil, but just whatever reason. And then you see the patient start ramping up. it gets worse. And while the physical stuff hasn't changed, it's that emotional support. And I tell you, it'll save lives. We've talked a lot about dialysis transports. We started doing one of this lady, and she had, and it seems like everybody in nursing home has dementia of some kind, right? It's always on every diagnosis. And she just was kind of, not gray in the heart attack way, but just kind of gray in the, I'm circling the drain, I'm not long for this world kind of way. She was diagnosed with dementia. We'd say, hey, Mrs. Smith, or, that's obviously not her real name. And she wouldn't respond. And I was in a bad attitude point in my career. And I was like, all right. And I wouldn't talk to her. We put her in a stretcher, did visual vitals, got there. Well, then something happened to my grandmother during that time. And my grandfather just raved about the medics and how great they were. And that's a whole long story I won't go into. And it changed my perception. And I started practicing what they did for my grandmother, just whether she responded or not, just talking to her. And in the 10 months that we were transporting, that was in the first couple of months, we saw her go from, and my partner started doing it, and other medics started doing it. And I think because my partner saw a change in me because I was still in the EMT and I'd had a troubled history up to that point. So he's saying, hey, this kid is doing something. Let's help him out. And we saw her go from that gray circle in the drain to vibrant and full of life and looking forward to when we were there and talking to us. And I was like, wow, all we ever did was that comfort. And it changed the rest of her existence at that point.
And sometimes that's just as much part of care as anything else that we're doing for these patients. And it's just as important for us to do as well.
And we do get caught up, especially if we're talking about some of the other things of ectopic pregnancies or bleeding or some kind of trauma, like the guy who ripped his sac open. We get caught up in the trauma and the medicine and the fixing of the problem, and we fail to treat the patient as a whole, as a person.
And that's the way we want to be treated.
Yeah.
So we can't treat causes of genital and urinary system emergencies.
Not really.
I mean, we can take things to provide comfort and lessens the effect of shock, but if you've got a bad laceration, about the most we're going to be able to do is help try to stop that bleeding.
Yeah.
It's going to take a physician or a nurse practitioner or a PA or somebody to sew that up and fix it,
On that guy with the fence, how did you not scream like a girl at first when you saw it?
I was like, holy, my eyes were like, whoa.
I can just imagine walking up. I'd just do that cartoon Wilhelm scream, like, what the hell?
I've been like, I was looking like, dang, that must hurt.
Yeah.
I'm glad I didn't, like back in the day when camera phones first came out and everybody was taking pictures. I'm glad I've never been one of those. And do not do this.
I wanted to
You will
be.
get in trouble, but it would have been hard for me to like, hey, dude, can I take a picture? Because it's one of those things that.
Oh, I'll be honest. I would absolutely have taken a picture of that if I had the camera. I mean, that's just one of those once in a lifetime.
Nowadays,
like,
you get in big trouble doing that, though.
Yeah, there's a lot, and we talked about that too on another one. But God, though, how many pictures of that are in existence?
They were taking pictures in the emergency room, but you got to realize the emergency room we were going to was a training hospital.
And that's a whole different ballgame, isn't it? Policies and everything else.
They've got the legal things out there. That's why you just can't take pictures in the field. They have to get permission, and then they black out the face with the the black lines and stuff, and but we got to treat for shock. Assume that shock is looming somewhere in these patients. So, provide oxygen, position of comfort.
Would you say, other than obviously trauma being a shock factor, the abdominal and the GU injuries, or emergencies rather, are probably the second largest cause of shock?
I don't know. I would think that they could be made because you could have sepsis.
Right.
You could have,
you
bleeding.
have a bleed. Yeah, I mean.
And then and maybe there's secondary causes, like if you had a ruptured bladder, well, that's going to leak and cause sepsis. And
because not all of these emergencies, trauma is not just they ripped it open. Right. I mean, you're talking about the possible femur fracture that punctured the bladder, which now you maybe not bleeding, but that's going to lead to shock.
Yeah.
And that came from a traumatic experience.
You mean pelvis fracture?
I said femur. I did mean pelvis. Yeah, sorry.
So after releasing the patient to hospital staff, make sure you clean the ambulance equipment and your hands, because you're talking about potential for potential infection being here, especially if there's substances that have leaked out of the patient. We want to make sure that we clean everything so that we're not causing those infections to spread throughout to our next patient or to us or whatever.